Welcome, everyone. Happy Tuesday. You have joined the Penguin webinar for the implementation of the Perinatal Mental Health Conditions Bundle. And today we're so excited to have three presentations from your hospital colleagues on data review and submission tips for this bundle. So Brooke and I are going to get going with a few announcements, and then we'll turn it over to our teams. Also wanted to wish you all a happy Black Maternal Health Week. This is an annual event from April 11th to 17th that serves to amplify the voices of Black birthing people and center the values and traditions of the reproductive and birth justice movements. So the last day of this will be on Thursday, and there are several activities and webinars and new information being shared every day, so be sure to tune in. I'll start with our very quick housekeeping items. As usual, please type your name and institution into the chat. Optional share for this month. The many April showers we've been getting so far will hopefully result in some beautiful May flowers this year. We'd love to know what your favorite flower is. Please mute yourselves when not speaking. Feel free to type your questions into the chat during the webinar. All of our presenters will be available to answer questions at the very end. And as always, this session is being recorded and we'll upload it with slides to our website afterwards. So again, Brooke and I will do some Penguin announcements and updates, and then we'll be hearing from our three speakers. Sandra will be speaking from Fairview Hospital about her experience using Meditech to submit data for this bundle, and then Courtney and Lori from Southcoast and Lowell General, respectively, both use Epic, and we'll round out our presentations for today, and then we'll have Q&A at the end. So with that, I'll turn it over to Brooke for our brief announcements.
All right. As Kaylee said, I'm going to cover some announcements and then I'm going to hand it back on over to her. She'll share some more about data collected so far in this bundle. The waitlist is enacted for the Penguin 2025 Summit. Please join the waitlist. Next slide, Kaylee. As was shared in our March webinar, the PMHC Bundle Toolkit and resource page, which is on the next slide, have been shared. Links will be in the chat. Now at the state level, you can, tomorrow is the March of Dimes March for Change, where attendees will receive information on priorities, and you can meet with your state lawmakers and share meeting feedback with their staff. You can learn more and register at the link that I will send in the chat. Next slide, Kaylee. And then you can support the Moms Matter Act. The Massachusetts Mind the Gap Coalition is working hard to improve perinatal mood and anxiety disorders, and you can help. I'll send a link in the chat where you can learn more. The MCPAP for Moms, our Massachusetts State Perinatal Psychiatry Access Program, is available as a resource to providers. As part of their training offerings, MCPAP is available to come to your institution. You can reach out to Beth McGinn for more information or to schedule a time. Next slide, please. We have the trailer is now released for the So Glad You Asked podcast. From the MGH Center for Women's Mental Health, where you can hear from co-host Dr. Ruta Nonax and Alice Hales, where they will cover conversations about things during pregnancy, postpartum, and beyond. And you can find that on Apple Podcasts or Spotify. Dr. Nancy Byatt is recruiting for the PCORI grant study, and she is out of UMass Chan Medical School. Any information that you're looking for, any questions you might have, please reach out to Dr. Nancy Byatt. I will send her email in the chat soon. And at the national level, There is a National Speak Up Champions Conference. We have two of them coming up on May 2nd and May 9th, both running from 9:30 to 1:30 p.m., where you can participate in a virtual training to outline strategies to help individuals and groups dismantle racism, provide quality, equitable care, and reduce health disparities. And you can register at the link I will send in the chat very soon. And that's it. So I'll hand it back over to Kaylee, who will share more about what's going on statewide in the bundle.
Awesome. Thank you, Brooke. So April is Penguin's annual reporting time. So we have been compiling information on hospital participation in this bundle, as well as on our various structure and process measures. So as we were doing that, we wanted to share an update with you all about the progress that we're making. As always, want to acknowledge the Perinatal Mental Health Bundle work group for all of their support on this bundle, and of course, acknowledge all of you, our 22 teams participating. Just a quick note on participation. I just want to say, ahead of the slides I'll present, congratulations on everything that you all have accomplished so far. Any amount of participation on this bundle is important, whether you're only focusing on one bundle component or only submitting structure measures at this time. This area of work is so critical that something is better than nothing. And so we just appreciate any and all efforts that you all are able to make each month to move the needle on perinatal mental health care in our state. That said, if you are struggling, please don't hesitate to reach out to the Penguin team. We're here to help, and we can, if you're feeling concerned about the amount of data you're able to supply or attendance at webinars, we can work with you to find a solution that works best for your capacity. So our participation check-in, I just wanted to highlight, well, and I'll say too that I'm going to go through these slides a little bit quickly just so that we can get to the teams who are presenting today. But all of these slides I'm going to touch on will be available on our website for you to read more closely later. So with this one, I just wanted to say again that we have 22 teams who completely onboarded to participate in this bundle with a team roster, the pre-implementation survey, and a signed MOU, which is incredible. And so far, everyone is meeting the goal that we've set of attending half or more of our webinars. So that's 3 out of the 6 we've had so far, and which is wonderful. So thank you all. I also wanted to, so this graph is from the implementation feedback survey that we've been encouraging everyone to complete since February. I wanted to just shout out that many of you identified the onboarding piece of putting together a team as one of the most challenging parts so far. However, it is really paying off because when we asked you all, what's been successful about implementing this bundle so far, there are several of these comments listed here shouting out the work of your multidisciplinary teams. So you have very engaged teams, very interested teams, you're meeting regularly, you're collecting data, the staff is very supportive of the work you're doing on this bundle, and there's collaboration among many different departments. So this is amazing. Thank you all so much. This slide has some details on what teams need guidance or tools for at this point in the bundle. So we asked you all about any challenges you were having with particular structure or process measures. And so I compiled all that information into a what teams need slide. So if your team is doing particularly well, or you have a provider education material for your health stream, or any tips for how to get a mental health protocol in place, please email Brooke or I, and if you have information to share, and we'll make sure that that gets back out to everybody else. One of these tools that was requested was an information on which payers are public versus private for our process measures, where we ask for information on insurance. And Brooke wonderfully put together a resource sheet with a list that we've compiled so far of the insurances that we know to be public or private. So that's available for you to use on the Penguin website, and we'll keep updating it as we hear of more payers. And I just wanted to say your feedback's important to us. So the reason why we're having this webinar on data submission tips and tricks is because you all asked for it. You identified monthly data submission as the most challenging requirement for this bundle. And you let us know that, Epic and Meditech are among the two most commonly used EMRs across the state. So that's why we have teams who are using those EMRs presenting today. So I know the surveys we send out can be onerous at times, but we really do read every single response and try and support you as best we can with the information we get. So lastly, I'll just run through our measures. I'm so excited to share that the 5 structure measures for this bundle are all improving since we started in September. So keep up the great work. We're also seeing increases in provider education. So in September, a little under 20% of providers and nurses had been trained on perinatal mental health conditions. And as of February, we're creeping closer to 50%. So please continue to educate your providers. This graph is on inpatient screening. In September, we only had 2 hospitals reporting on this measure, and they had reported zeros across the board for all of our demographic groups. But now in February, we have 7 hospitals reporting, and we're getting close to around 70% for each group, which is our goal. And there's very little inequity amongst all of these groups, which is incredible. This is our process measure for patient education on perinatal mental health conditions. In September, again, we only had a couple hospitals reporting, and the numbers were a little all over the place, with some inequities among most of the groups. But now, as of February, we've exceeded the goal for all groups, and the inequities have decreased. So please keep up the great work. And with that, it's my pleasure to turn it over to Sandra to talk about using Meditech at Fairview for this bundle.
Good afternoon. I'm speaking from the Berkshires, Great Barrington, Mass. We're at Fairview Hospital. It is, we could go to the next slide. I'm sorry, I have the incorrect date on this first slide. We're an affiliate of a larger corporation called Berkshire Health Systems, and Fairview is a 25-bed federally designated critical access hospital. We are a sanctuary city for immigrant population, and that we have probably 20 to 25%, maybe 30, are the more vulnerable population because they are at risk of, especially with all the DEI anticipation, and our area is very, very, favorable to protecting that and making it a safe area for our population. We do about 100 births per year at the family birthplace. We have an LDRP style unit, 5 suites, including 1 outpatient observation room. We are baby friendly affiliated and teen birth designated. Next slide, please. So our objectives, as were the main objectives that we began this bundle with, to educate our staff, patients, and their families regarding the increased occurrences of perinatal mental health diagnoses. We began an article research back in mid last year when all of this mental health bundle really came to fruition with you guys, but also in many of the journals. And it was found to be a very popular topic among all the nurse submitting articles at our unit council meetings. So the timing of this was amazing. We are now meeting with our patients on the perinatal level in the office with screenings, and also at a 32-week screening opportunity in what we call a PAT. It's a pre-admission talk. It's very rare to have this kind of meeting. It's nothing that we charge for. We meet with the patient and their family, partner, whoever their support people will be, and we screen them at 32 weeks, both the GAD7 and also the Edinburgh screening. And we keep that right documented in their record, so we can follow them from the 32-week through their admission, through their stay, postpartum, and also we do postpartum follow-ups to prevent any decline in their wellness or any occurrences that we can be more helpful with. We do offer outreach access for the perinatal time. We have a wonderful social work department that we can refer to from that 32-week visit. Our OB office that we are affiliated with uses McPap also for referral. And one of our primary care office settings has a psychologist on staff. So if they have that insurance through that community health plan, they do not need to wait very long for a referral, which is even if it's the parents and the child is a patient in the CHP grouping, that mother can have an automatic referral with the CHP psychiatrist on staff. And the pediatric staff of that office are very much in touch with us regarding anyone who has concerning scores on their Edinburgh post-delivery pediatric visits. We remain in very close touch with the pediatricians, the obstetricians, and the social service system. Obviously, you want to prevent any risks that contribute to the maternal morbidity mortality population and the referral that I just spoke of. Next slide, please. So our first antepartum visit is in the office. Like I said, it's the GAD-7 screening for anxiety and the Edinburgh. And the obstetricians are very good at communicating with us if they have concerns. Our pre-admission tour is a tour of our unit, of the rooms, the entire facility. It usually includes patient and one support person. We help them develop a birth plan if they have not. We discuss team birth with them. We discuss all our analgesia options if they request for labor, their medical history, and we also discuss the mental history of the patient and risks that may be in place, or if they're having antepartum diagnoses or concerns. We pretty much discuss it right from there with our pre-admission interview. Upon admission to the birthplace, we do our DEI screening, Columbia suicide screening. Also, I found that the medication list sometimes can be a little segue into the discussion of their maternal mental health if they're not, if they're quiet, or if they need an opportunity to bring up any concerns that they have. And we have found doing these screenings in person have made patients feel a little less vulnerable and a little more open with their histories and concerns and their histories of any postpartum depression. I have found that very helpful. We do discharge teaching throughout the postpartum period, or we also do some teaching if someone is having like an arrived trial induction and we have a day of early cervical ripening that we can discuss some of these topics and then follow up with them in their postpartum time and their discharge follow-up. We also give multiple outreach handouts on the local level, state level, and the national level. And then we do a postpartum follow-up phone call at 3 days. And then if we have concerns or make contact with someone and have an agreement to follow up with them again at 7 days, we do that as well. Next slide, please. We have about 100 deliveries a year, which does represent a low volume. And in that piece, the data collection is, I'm sure, much less voluminous than the bigger facilities. And because of that, we really have a one-to-one patient nurse ratio, and we're able to deeply review every chart to achieve those bundle objectives. In the Meditech, my biggest source for the is the demographics and the information for the patient as far as their insurance, their any kind of referrals to other physicians that have been necessary. And through that, I'm able to get all of their information, personal information, to put together for our data collection. So usually the demographics, and then in Meditech, we have an intervention for our multidisciplinary maternal teaching, for our shaken baby and newborn teaching, and specific postpartum depression, discussion of signs and symptoms, risks, vulnerabilities, and potential follow-up. The obstacles we have faced is mostly gathering, how do I want to word it? I've been calling different outreach numbers and telling them exactly why I'm calling, because I'm not necessarily a patient, but I want to know what the patients are going to face if they call these numbers. And many of our psych follow-up people are expensive, very hard to get a hold of. So that's been our biggest barrier, but the hospital has probably the best referral system we have, and the obstetric office. Some of the this is mostly a nursing driven project here. We do have a office with 4 obstetricians who do communicate very well with us if needed, but it is mostly nurse driven to bring up some of the topics that either the doctors don't have a lot of time for, but we at the bedside have all the time in the world. Finding the right time in a 48-hour stay to interview and educate the patients does make it difficult, because they stay 48 hours from delivery. So from having that golden hour, skin to skin, you really don't want to interrupt that a lot. We also want to give them time to learn newborn care, which rooming in is the best way to learn the cues and how to care for their children. So somewhere in that 48-hour stay, preferably not discharge day, in my view. And here we really do our best to just go in depth in that middle 18 to 24 hours in the 48-hour stay. And then we do a summary upon discharge teaching also, just to revisit those topics, because that we try to discuss timings of signs and symptoms, baby blues compared to postpartum depression, and then any further involvement to either call here, the unit, or the doctor's office. And the other little obstacle, we're waiting for our clerical people to introduce the GAD-7 into a work list intervention along with the Edinburgh to dissolve any paper trail that we have. Next slide, please. We do, like I said, we meet with them at 32 weeks just to make sure we discuss their preferences, if they have any cultural practices or requests, or if anyone has had a previous experience that we can help them work through in forward facing their delivery, or we use our communication board for our huddles. And if there's any specific, the nurse is very, very good here at advocating for the patient's request or any concerns from any previous trauma. Next slide, please. I think, does anyone have any questions, or is that going to be at the end of the presentation?
We'll hold them for the end. Thank you,
Okay,
Sandra.
great.
Thank you so much.
Thank you.
Thank you, Sandra.
Thank you.
If anyone has any questions for Sandra at the moment, feel free to put those in the chat so you don't forget. And we're going to move on to our next speaker. Take it away, Courtney.
Hi, good afternoon. I'm Courtney. Next slide. I do the data collection for Southcoast Health. Next slide. So we are two hospitals that is in a system of 3 hospitals. So St. Luke's, Charlton, and Toby, which no longer has maternity care. In terms of submitting data through Penguin, we're 2 separate hospitals, but we use a quality partner called Premier, and they consider us one system. So sometimes getting data can be a little challenging just in that respect. Overall, our system has done 3,160 deliveries in the last year, breaking down to 1,830 at St. Luke's and 1,330 at Charlton. What we report on is the perinatal mental health conditions bundle, the maternal equity bundle, and the opioid substance use disorder bundles. And then we have the demographics on the following slide, if you can skip to that one. So our payer mix at Southcoast is 74.6% public health insurance, which was talked about at the beginning of the bundle, and 25.4% commercial or private insurance companies. The data sets that you see here are from our quality partner, Premier. We're part of a perinatal collaborative, so it allows us access to this data for our sites. It compares us to others in the collaborative as well as a peer group. So as I said before, we're considered one site, so the demographic information is just going to be for both sites. But as you can see, the majority of our patients identify as white with 61.4%. Other is 14.5%, which is our second largest group, followed by unable to determine at 12.9%. Rounding out our top 5 biggest groups with patients identifying as Black at 9.5 and Asian at 1.5. Next slide. This is also out of Premier. So again, both hospitals are one system. This is the ethnicity for our patient population. As you can see, most of our patients identify as not Hispanic or Latino with 65.9%. 20.4% identify as Hispanic, and then we have 13% that identify as unknown. Next slide. So just a brief overview of how I do data collection. I start by opening my reports in Epic, and I go to the pregnancy dashboard, which you can see on the left-hand side. On the right, I use birth certificate all data, where the little star is. When I open it, I click on the pencil so that I can select out the month that I'm interested in. The only challenge is that we're reporting data from previous months. So for example, we're going to be submitting our data on May 10th. And it will actually be our data from March because that's what we have completed birth records for. Next slide. So doing this, you can actually filter for race, ethnicity, birth location, delivery, payment. As I said, I do the data for both St. Luke's and for Charlton. So this is really helpful for me to be able to separate out by birth location. So I'm sure that I'm getting one site versus the other. I grab all my data from here first, and I have an Excel sheet where I put the MRNs to do chart review for the metrics that we report on monthly. As you can see on the lower right hand, it's small, so I apologize, but that's where it will tell you the total number of deliveries when you have all your filters in place that you're looking for. I use delivery payment to determine if they have private or public health. So prior to Penguin having their list, we worked with our integrated care management manager. She actually sat down with us and helped us to create a list of private versus public insurance payers. So that's what I was using. And then from this point, I select charts to review, put them in my spreadsheet to keep track of everything. This isn't something I get done in one sitting. I kind of start working on it as soon as I submit the last month. And then throughout the month, I, get my MRNs together and then do all my chart review. Next slide. This is a screenshot of the spreadsheet I use to keep all my data organized. Because I do both sites, it's just easier to gather all the data this way. That way, when I submit, I'm just looking at this Excel sheet and putting it directly into the submission form. It's just easier for me than going back and forth through Epic. Next slide. Slicer Dicer has been instrumental for us in terms of reporting. We worked with the manager of patient care business ops, and he helped us make some reports in Slicer Dicer. So all this data that we're submitting is not something that we figured out on our own. We had a lot of help, which was awesome. He actually explained to us that through Slicer Dicer, we would be able to access patient level data. Through Southcoast, we did have to take a quick class that was in our online database called Learn More. And then from there, we created our own reports. He created a couple for us, and those are the reports we use every month. So if you're going to start to create a report or you just want to look through births, if you click on births, that will help you access all your reports. Next slide. This is just a snip of some of the reports that I used. So mothers with severe hypertension and newborns with SUD exposure were made by the manager of patient care business ops. We were able to email him what we were looking for. I believe it was after the first month when we were submitting data. We kind of had a good idea that we would need some help just finding what exactly we were looking for. So we sent him emails with what we were looking for. He was able to create these in Slicer Dicer, and then he actually sent them to us through Secure Chat and Epic, which was awesome because it allowed us to open up right into the report. The new group slides are my most used reports, and this is where I also get my preferred language patients. Because of the access I was able to get in Epic, I can use Slicer Dicer, like I said, to get down to patient-specific MRNs, which has been really helpful. The highlighted report that you see in blue is the ICD-10 codes from the AIM bundle. I took all those codes and put them into a report. That way, every month, it's pulling from that. Once all the reports are created, it's pretty easy to run them. You just have to remember to change your specific dates. It doesn't regenerate new dates. It'll go off of the date that you created the report, and then you just change your date. Next slide. This is just an example of what the inside of a report would look like at a glance. So the slices in Epic are what you're going to use to filter. So as you can see, I have the slice for preferred language, and I also have the slice for delivery location. So it broke out for me just deliveries at Charlton for the month of March, and it broke down our English-speaking patients and our not English-speaking patients. You can also filter for race and ethnicity, which is helpful for a lot of the reporting. And then where the little star is, again, I apologize, it's small. You'll see 3 bars. That's where you can go to get the patient-specific MRNs. I don't know if it's specific facility to facility, but I know for Southcoast, I had to take a class and request special access through my manager for that. Next slide. The last thing is just quickly what we do for chart review once we have the MRNs from the reports. So we have in our postpartum flow sheet, there is a little section where nurses document if the Edinburgh score was given out to patients upon discharge. And actually, Epic is really good about explaining what handing it out entails. It entails explaining how it's used and things like that. So we look for if there is a yes filed or no answer filed for the hypertension report. In the summary tab under Epic, we do like a vitals review. And like I said, that report was built for us. So it looks for anybody who's had 2 blood pressures that are 160 over 110 or above. But the vitals tab has been helpful to just see if they met the criteria within the 15 minutes. We use the ACOG definition. And then we look at notes from social work for treatments and medications before or during pregnancy. Next slide.
Wonderful. Thank you so much, Courtney. Having those visuals from Epic, I think are really, really helpful. We're going to move on to Lori at Lowell General, but I did want to just point out that Michelle put a question in the chat. I don't know if this was just to the Southcoast team or for everyone on the call, but she's just curious what everyone's using for your SUD screening tool. So feel free to put that answer in the chat. Okay, it is for everyone. Thank you, Michelle. All right, wonderful. And now I'd like to welcome Lori.
Hello, my name is Lori. I'm the clinical leader of postpartum on the at Lowell General. And I actually, the data collection, I share the responsibility with Kristen Sparks, who's the clinical leader of pediatrics, but she's on an LOA right now, so she wasn't able to join us. Next slide. Next slide, sorry. So Lowell General is under the Tufts Medicine umbrella. We don't do LDRP. We have a labor and delivery unit with 12 labor rooms, 2 operating rooms. We do have an OBED with 3 rooms and then 5 triage rooms. The mother infant unit is a 22-bed unit for moms and a 20-bed nursery, crib, sorry. And then the special care nursery is a level 2B nursery with 10 beds. We do have an overflow area if needed if we go more than 10 babies. And our pediatric unit is a PD/adult unit now, and they are a 20-bed unit. And last year we did 1,805 deliveries. We kind of can, that's like plus or minus probably 100 deliveries per year. We have a fluctuation there. Next slide. So a little bit about our project. I have a slide coming up on the diversity in our population of patients here, but we do recognize there are disparities in maternal mental health. And so our project was to kind of do an overhaul of our education for staff. We broadened it from just the postpartum and labor nurses to the pediatric department and special care nursery. And then we actually did a presentation at our research fair to open it up to other units in the hospital because they also see some of our patients in that perinatal period. So this education was rolled out and available for the hospital if needed. Next slide. So this is, we have a really rich culturally diverse community, which is one of the things I love about working here. So when we do our data collection, this is a bit of a breakdown of what we look for our data. And we do have a full interpreter service department where we have iPads and live interpreters here at the hospital, which is great for that. Part of our project was that all of our handouts and such were primarily in English, so we also broadened that. So our handouts and our magnet that people can take home after they leave with signs and symptoms of perinatal mental health conditions and resources are available in Spanish, English, Khmer, Portuguese, and Haitian Creole. Next slide. This is our perinatal mental health team. It involved the outpatient clinics as well as the Lowell General. I think I love that Sandra is working with that smaller population. I would love to have the contact you have with your patients. I think it's fabulous. We have more deliveries. We service primarily 3 of the bigger OB offices in the community and then some smaller ones as well. So some of that data collection for prenatal care is difficult. And then same with the postnatal once they're discharged. It's a little bit more cut up, which I wish we had it like Sandra had it. But so this was our team. It involved leadership, physicians from the community offices, as well as inpatient, and all of the clinical leaders in the MCH division. Next slide. We do have the anti-racism statement comes from our equity work group at Lowell General, and this is displayed outside of all the MCH units. Next slide. We shared this at the Nursing Research Fair for the hospital as well as the Pinkman Fall Summit. We did a poster presentation. Next slide. So our timeline starting in May, we established the team and then we created the new documents for education. We created a learning central for our staff education. We created the magnets to be distributed in all the languages to patients. And now we're into the data collection with chart audits and such, and we do use Epic for that. Next slide. So one of the things we did, like I said, we expanded our education as far as what's covered. We historically spoke to perinatal depression, because that was the most common, postpartum blues, postpartum depression. We now include all these other conditions as well. And we also, like I said, opened it up in primary languages as well as to other units in the hospital, because they also see these patients who are high risk. Next slide. This is just a picture of the magnet. The QR code brings them to the Perinatal Support International website, and it brings them, if it's a KAMI magnet and they scan that QR code, it brings them to that website with all the KAMI information in their language, so they don't have to click around once they get there to the website. Next slide. Posters were hung in all the MCH units as far as supporting the mother and signs to look for. Expanding the information to families helped to decrease stigma around perinatal mental health conditions. That helped our staff more easily speak to it, where it didn't feel like they should only talk to the patient, they should involve the family. Next slide. This is the education form that we give patients. Again, it's available in all the languages I mentioned earlier. And it says for each condition, it says which ones you would call an OB office versus postpartum psychosis, which would be an emergency, and not to try to handle that on their own at home. Next slide. So as far as the data collection, we also use Slicer Dicer. We did reports differently. There are different ways to do reports to get your data. I think that Courtney's are probably more streamlined than ours are. So I'll be rereading her slides. But what we do is Kristen and I kind of split in half the data collection. We pull our reports similarly to Courtney, but we just find them in different places. And then we each do half of the data collection. Some of the challenges with Epic, specifically for the data collection for our project, in Epic, one of the challenges was in Epic, we are Tufts, Melrose, Wakefield, and Lowell General. And we need all three hospitals to change anything in Epic to agree that they're using it and this is something they want. So what we wanted was some sort of when we go into a chart to do an audit on a non-English speaking patient, if they received education inpatient, for example, there really was nowhere to put that where we could just easily find it. And we needed staff following the nurse who distributed the information to easily see the patient already received the information, so we're not redoing. So we did have to work with our Lowell General Epic to find a place to put a note under the education tab for psychosocial education. So once we found that way to go in to document where other staff can see, then we were able to more easily pull the data after the discharge when we were looking for the data. So now when Kristen and I go in our reports, we can more easily find that. And I just thought it was easy to break it down according to when you actually submit your data, there are all of the categories. So P1 for provider and nursing education. All of our nursing staff mandatorily did trauma-informed care as is necessary in our jobs. It's not a requirement for our providers. So when we submit our data, the provider value is usually 0 and the nursing is much higher. So the next step would be we're trying to get that into the provider education. We're working with their leadership for that. As far as the prenatal screenings for perinatal mental health, some of the offices that we that feed into our system for their deliveries use Epic and some don't. It's really difficult to find in those offices who use Epic where they consistently would document screenings. So that's a big challenge for us. So we need to work more closely maybe with their nursing leadership that have started meetings with them to try to see how we can go about getting the data collection from that. Like I said, with the bigger hospital, I think it's more broken up between the outpatient clinics and the inpatient world. So trying to figure out how to get that information is a big challenge. And it's the same thing for the postpartum education. We go in and do the chart audits. The timing of the audits, because we do our data just for the previous month. Sometimes those postpartum appointments haven't actually happened yet. So we can see that they're scheduled. I happen to have worked at Circle Health OBGYN, which is the biggest group that feeds our system. So I know that they use the Edinburgh at the 28-week visit, and I know that they scan it into the scanned documents portion of Epic, so I can see those, but I can't see the offices who don't use Epic. So that pre and post data is really hard to find. And then for screening, I'm sorry, I got lost. I think that's it. So next screen, please. So I think that some of our accomplishments through working with staff via huddles and things as far as the documentation in Epic, they're much more able now to find exactly where they need to go to document the data. They find that the magnets and handouts make it easier to speak to patients about the perinatal mental health conditions and to document in real time. It's kind of, I think sometimes the conversation was more challenging for them to bring up, but now they kind of have a speaking point with the magnets and things. So creating that new handout and magnets was huge for staff support. They're also verbalizing much more ease at the documentation, and so they're happy with that. Next slide. So this is our data. You can see oh, it's not on here. The go live was November 4th for our data collection. This slide is changed a little, I think, when it was uploaded into this presentation. So we are up to between 80 and 80%. We started off at about 20 to 30% of good documentation in the medical records, where we could pull the data easily for the REDCap. And now we're up to the documentation is 80 to 88%, which is really great. And follow-up pulling of the data outpatient is still a challenge. But like I said, I've started outreach with those offices with the nursing leadership. So we'll be working together to try to streamline that a bit as well. Next slide.
Sorry about the change in the graph, Lori. We'll make sure that's
okay.
accurate before we upload.
That's okay. So for the next steps, we're continuing the chart audits. We end up, I think, because it's a new process for us. We usually do more than the 50 chart audits every month. The way that the audits are set up, you want to take every 5th chart or every 7th, depending on how many charts you have that month. We usually do that, and then we do more of the data collection on our own to see where we can improve and what we need to work on. The data collection is great in Epic because once you get that out in your reports, I mean, then the next month you don't have to redo all your parameters. You can just pull that up. And then, like mentioned earlier, you just have to make sure you change the dates or you're going to get 2024 data, which is not going to be good because the project had started then. So, and so these are just accomplishments. And in general, we have 2 nurses. I'm one of them who's going to be completing my certification in perinatal mental health, which is great. And this is still offered throughout the hospital for any other staff who need to support these families. Next slide. Oh, and these were the other bundles that we took part in through Pinkwin. Next slide.
Wonderful. Thank you so much, Lori. It's so helpful to hear about your challenges and successes. All right, we are 1 minute early for Q&A, which is hardly ever happens. But I want to thank all of our presenters so much again, Sandra, Courtney, and Lori, for being willing to share about your data collection strategies for this bundle. So at this point, we have, like I said, over 10 minutes to answer any other questions. There have been some in the chat already, but I just welcome anyone to put any further questions in the chat, or you can come off mute. Also, if there are anyone else on the call who use any other tools for data submission for this bundle, now's the time to share. We'd love to hear it. So I'm going to stop sharing so we can see each other. Yeah, Tiffany?
Well, I was just going to thank everybody who presented today and for the amazing work that's being done around the data and the timely submission. I know we have something new to aspire to at our own hospital. This is wonderful.
Is anyone struggling with submitting data for any particular measure for this bundle? The structure measures seem pretty straightforward since it's just that 1 to 5 Likert scale. But what I've heard just anecdotally is it's the process measures around education and screening and discussions for treatment that are the trickiest ones. Yeah, Sarah.
So I'm not answering that specific question, but I did want to ask, so I know at Lowell who our primary data collection folks are, but I kind of missed the roles at the other 2 hospitals, and I wondered if folks could just, like, what are your roles? Are you clinical leaders? Are you in some other role?
Yeah, go ahead, Sandra. Oh, you're on mute.
Hi.
Here we go.
I'm a staff nurse. I'm 60 years old. I've been doing this for almost 40 years. I'm very fortunate to do the one-on-one with our census. It's a very unique unit. And we meet our patients quite frequently in the antepartal period. So that allows me to become connected with some people who, you know, you really bond in those interviews and the pre-admission tours. And we have the time to spend with them. It takes about an hour for our pre-admission talk. And people really know what to expect when they come in. We discuss team birth so they know how important their role is in communicating their birth plan and feeling like they are the center of their care and the decision makers, along with myself, the physician, and the other members involved in the huddle. That was really, the team birth was really what brought a lot of this together. We were baby friendly first, then team birth came and really changed the setting a little bit. It really made people feel empowered. And like I said, we do a fair amount of those arrived trials, and we have a lot of time on our hands to teach about postpartum depression and to focus on mom time and sharing the wealth of newborn care with your partner and your family, and trusting us because we do have a long-term relationship with them. And patient I just had a delivery with, it was their 4th child, and I was with them for every child. That doesn't happen at the bigger facilities, and it was amazing. And I'm very lucky. I was searching for years after I left a hospital after 34 years, which was a shame to have to leave, but I needed to find out how other hospitals were doing it. And I've been able to be in touch with more with these bundles with a smaller facility. And if anyone has any questions about the Meditech data collection, it's really all in the demographics, all in the Meditech work list, and the nurse's notes. Those are my 3 sources, and it really simplifies a lot. Never thought I'd say that about Meditech, but that has been very helpful.
Wonderful.
Sandra, and we're in the process of rolling out team birth on labor here at Lowell, so that's encouraging.
Oh, best thing we ever did.
It's amazing. Thank you, Sandra.
You're welcome.
Courtney, when you have a moment to either come off mute or just put in the chat what just reiterate your role at Southcoast, that'd be great.
Hi, so I'm an innovations nurse specialist. I'm one of two for obstetrics. A lot of what we do is quality safety, so data collection, policies. We're working on creating the newest evidence-based practice. And one of the examples of that is we just recently rolled out an induction of labor project that we had worked so hard on to involve dual agent ripening with balloons and meso. So that's just an example of some of the things that we've worked on, but that's my primary role. And then I'm also per diem at Charlton, so I work in postpartum and the labor room.
Thank you.
Thanks, Courtney. We've got about 4 minutes left in our time. Any other questions for today's speakers or questions related to data submission for the bundle in general? I do want to reiterate that again, you all told us in the implementation feedback survey that the data submission was the most challenging piece for this bundle. It's not unusual. It's been the most challenging piece for all of the bundles we've done so far. But Penguin is here as a resource, as well as our colleagues at the Betsy Lehman Center for Patient Safety, who put out the survey every month. So if you're still thinking about data submission or want to have a one-on-one call with Penguin about, just to share what you're struggling with or to ask for any help, you can always reach out to me or to Brooke to set that up. We'd be happy to do that. So I'm not seeing any more questions in the chat or hands raised, so I think we can wrap up early, but before we do, I'll just invite any of our speakers today, Sandra, Courtney, Lori, any kind of parting words on data submission tips for everybody?
I would just say it does, the chart audits do, at least for Lowell here, they do take some time. So it helped us immensely by just dividing the work. So Kristen takes her half, I take my half, and then we actually sit and meet together and enter the data together into REDCap. And that helped because it seemed like once we started doing them, it seemed like an overwhelming task aside from our other, because we're clinical leaders.
Right.
So we're a mix between helping manager and helping staff nurses. We're kind of pulled a lot. So initially that was like a daunting thing, but when we split it, it was much more manageable.
I think that's a really wonderful note to end on, Lori, because I know a lot of people are strapped for staff and for time these days, and it seems a little bit rare that there can be one person in charge of quality data at a hospital. So dividing the work and doing it as a team, I think, is really wonderful advice. Thank you. Sorry, Tiffany, did I cut you off?
No, that's exactly what I was going to say. It's a great pearl to end on.
Yeah, great. All right. Oh, and Sandra also says, thank you for this wonderful monthly opportunity for growth of our unit, and data submission gets easier each time I submit. Wonderful. That's also encouraging.
Yeah.
Thank you, Sandra. All right. Well, thank you again to our presenters today, Sandra, Courtney, and Lori. You all were wonderful. Thank you all for being here. The reminder that we do not have this webinar in May due to the Penguin Summit on the 22nd. So we'll meet back at this time on the third Tuesday at noon in June. Brooke, Tiffany, and I have a meeting after this to kind of iron out our next few webinar topics. So we'll continue updating the schedule for you all. And we hope to see you at the summit. Don't be discouraged if you add your name to the wait list, because spots do free up as people iron out their schedules. So you can still come. All right. Thanks, everybody.